Thank you and good morning, Chairman Hurd, Ranking Member Ledger Fernandez. Likewise, it was an amazing event out in New Mexico and really a clear demonstration of self-determination, self-governance, targeting youth, and how that fits into the theme of today's oversight hearing. I also want to thank the members of the subcommittee and our tribal leaders who are in the room with us. My name is Benjamin Smith. I serve as the Deputy Director at the Indian Health Service, and thank you for the opportunity to present testimony at today's hearing on the critical matter of 638 contracting and compacting within the Indian Health Service. The Indian Health Service is an agency within the Department of Health and Human Services, and our mission is to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. We carry out this mission in partnership with tribal communities through a network of more than 600 federal and tribal health facilities, as well as 41 urban Indian organizations across 37 states. Together, these systems provide healthcare services to approximately 2.8 million American Indians and Alaska Natives each year. The Indian Health Service is the 18th largest healthcare system in this country. Our system includes 12 area offices that oversee 170 service units, which are the facilities that provide care in local communities. Health services are delivered in three main ways within our system. They can be managed directly by the Indian Health Service through tribal health programs, meaning a tribe or tribal organization operating under Title I or Title V of the Indian Self-Determination and Education Assistance Act, or through contracts and grants to urban Indian organizations as authorized under the Indian Healthcare Improvement Act. As was mentioned, 50 years ago, the Indian Self-Determination and Education Assistance Act marked a monumental turning point in federal Indian policy. It empowered tribal nations to reclaim authority over essential services and to make decisions about matters that directly affect their communities. I want to thank this subcommittee for holding a field hearing earlier this year to commemorate the 50th anniversary of this landmark law. Both Title I and Title V of the ISDEA authorize the Secretary of Health and Human Services to enter into contracts or compacts with tribes or tribal organizations upon their request. The key distinction between self-determination contracts and self-governance compacts is the degree of tribal flexibility. Both of these authorities transfer programs, services, functions, or activities that would have otherwise been provided by the Indian Health Service. But one key difference under Title I in particular, the Indian Health Service must approve any substantial changes to a contract. Where under Title V, a tribe may consolidate any of those programs, services, functions, or activities, or portions thereof, and reallocate funding under their compact and funding agreement without Indian Health Service approval, provided that the redesign does not deny eligibility for services. We do have a growing volume of the work, as was mentioned. In fact, in fiscal year 24, for Title I self-determination contracts, we had a portfolio of 247 contracts, reflective of 232 tribes and tribal organizations. Under self-determination title, or self-governance Title V, IHS was party to 114 compacts and 141 funding agreements. Through both mechanisms, we transfer approximately $3 billion of the IHS budget to tribes and tribal organizations. Today's hearing, Modernizing the Implementation of 638 Contracting at the Indian Health Service, is absolutely important to recognize that Public Law 93-638 in itself continues to evolve in practice, particularly through the distinctions between Title I and Title V that I mentioned earlier. Although not all tribes choose to enter into contracts or compacts, those that do have meaningful options that reflect their unique priorities and circumstances. The steady increase in tribes electing to contract or compact since the enactment of the ISDEA is another sign of modernization. We have moved from a time when the Indian Health Service was the primary provider of healthcare and programs in Indian countries to a system which approximately now has 62% of the Indian Health Service budget that's tribally managed and operated. As we contemplate moving in towards modernization, we do need to acknowledge the recent Supreme Court decision in Becerra versus San Carlos Apache, the level of work that contract support costs in Section 105L has added to the agency's statutory requirements. Secondly, electronic health record modernization. We can't leave Indian health system or Indian country behind. And finally, addressing some of the challenges of infrastructure and workforce. I have details included in my testimony, but with that, thank you for your commitment to improving healthcare for all American Indians, Alaska Natives, and I'm happy to answer any questions.